Heart failure, one of the most common, deadly, and misunderstood emergencies in modern medicine. Today, you're getting the ultimate crash course, simplified, clinically accurate, and designed for med students, nurses, and frontline clinicians. Stick to the end for a quick-fire management algorithm used in clinical training and medical education. Let's dive in. Heart failure isn't a single disease, it's a syndrome. It happens when the heart cannot pump enough blood to meet the body's metabolic needs, even when filling pressures are normal. Clinically, it shows up as shortness of breath, fatigue, orthopnea, ankle swelling, raised jugular venous pressure, pulmonary crackles, and an S3 gallop. And remember, the most important step in evaluation is identifying the underlying cause. This could be ischemic heart disease, hypertension, valvular disease, cardiomyopathies, thyrotoxicosis, congenital heart disease, and more. Acute heart failure means symptoms appear suddenly or worsen rapidly. Most patients have worsening chronic heart failure, but others present with de novo heart failure, symptoms appearing for the first time. To classify acute heart failure, you only need to ask two questions. Is there congestion? And is there hypoperfusion? These create the classic warm, cold, and wet, dry profiles. Warm means good perfusion. Cold means low perfusion. Wet means congestion. Dry means no congestion. Big triggers for acute worsening include tachyarrhythmias or bradyarrhythmias, acute coronary syndrome, pulmonary embolism, hypertensive crisis, cardiac tamponade, and aortic dissection. Slower triggers include infection, anemia, pregnancy, thyroid disorders, renal failure, and medications such as NSAIDs, calcium channel blockers, or improperly used beta blockers. Identifying these factors is crucial. They change treatment instantly. ICU admission is necessary if the patient has cardiogenic shock, respiratory distress with oxygen saturation below 90% that doesn't improve with oxygen, dangerous arrhythmias, acute coronary syndrome, hypertensive emergency, or altered mental status. A general ward admission is appropriate for worsened congestion or dyspnea at rest that improves with oxygen. Diagnosis of heart failure is clinical, but investigations guide management. To uncover the underlying cause, order an echocardiogram, ECG, and chest X-ray. To identify precipitating factors, check a complete blood count, ESR, thyroid function tests, renal tests, urinalysis, blood cultures if needed, and pregnancy test when appropriate. To guide treatment, monitor sodium, potassium, creatinine, BUN, and liver enzymes. Heart failure severity is classified using the NYHA system. Class 1 has no limitation, Class 2 has slight limitation, Class 3 has marked limitation, and Class 4 has symptoms even at rest. Structurally, heart failure progresses through stages A to D, from high-risk patients with no symptoms to advanced refractory heart failure. The goals of treatment are to improve symptoms, optimize volume status, restore oxygenation, identify and treat precipitating factors, correct the underlying cause, and optimize long-term therapy. Non-pharmacologic therapy includes salt restriction to less than 2 grams per day and fluid restriction to 1.5 to 2 liters in hyponatremic patients. Give oxygen if saturation is below 90%. Diuretics are the backbone of acute heart failure treatment. Before starting, check kidney function and electrolytes. For patients who are not already on diuretics, start with 40 milligrams of IV furosemide if blood pressure is above 90/60. Double the dose every 2 to 4 hours until urine output exceeds 1 milliliter per kilogram per hour. Patients already taking oral furosemide should receive the equivalent IV dose. Once a dose works, maintain it 3 times daily. Add spironolactone 25 to 50 milligrams per day unless potassium is high or renal function is severely impaired. Continue ACE inhibitors and beta blockers if the patient is stable. Otherwise, hold them temporarily. Monitor the patient closely. Check vital signs every hour until stable, then every 4 to 6 hours. Track fluid balance every 6 hours. Record daily weights. The target is 1 kilogram of weight loss per day. Check electrolytes and renal function daily. The goals of diuresis are negative fluid balance, improved breathing, reduced crackles, reduced edema, lower JVP, and improved kidney function. Watch for signs of overdiuresis such as dehydration, hypotension, or a rise in creatinine. If the patient is not responding, confirm they are taking medications correctly, eliminate NSAIDs or other interfering drugs, and ensure precipitating factors are being treated. Then escalate therapy. Increase furosemide to a maximum of 400 to 600 milligrams per day, increase spironolactone, give furosemide more frequently, consider continuous infusion in the ICU, or add hydrochlorothiazide 12.5 mg, taken 30 minutes before furosemide. Digoxin can help in patients with atrial fibrillation who need rate control and mild inotropy. As the patient improves, reduce diuretics gradually. Restart ACE inhibitors and beta blockers when stable. Begin these medications in new cases of reduced ejection fraction heart failure. Switch from IV to oral diuretics before discharge and observe the patient during ambulation. Before discharge, educate the patient about salt restriction, medication adherence, activity, and danger signs. Provide prescriptions, document the treatment plan clearly, and schedule an early follow-up, ideally within 1 week. Heart failure is complex, but with structured assessment and early management, outcomes improve dramatically. If you found this breakdown helpful, hit like, subscribe, and share this with a med student or colleague who needs it. Stay sharp, stay curious, and I'll see you in the next clinical masterclass.